Very good afternoon. Welcome to all of you, all the leaders of our state and national leaders. Welcome to this Indian Medical Association Academy of Medical Specialties AMS Tamil Nadu chapter program. This is the third webinar. The purpose of this webinar is today's webinar is mainly to commemorate World Glaucoma Day and World Sleep Day and World TB Day. So welcome to all. This is the program agenda. So we'll start the meeting with prayer. May I request our Joint Secretary of IMA AMS, Dr. Adar Senthil Kumar, for the physician prayer and IMA prayer.
Thank you, sir. Very warm greetings to all. The physician prayer. Dear Lord,
Sir, make other self mute, sir, please.
Arvind, kindly mute everyone.
Physician's prayer. Dear Lord, though great physician, I kneel before thee. Since every good and perfect gift must come from thee, I pray, give skill to my hands, clear vision to my mind, kindness and sympathy to my cause. Give me singleness of purpose, strength to lift at least a part of burden of my suffering fellow men, and the true realization of the rare privilege that's mine. Take from my heart all the duty of goodness, that with simple faith of a child I rely on thee. I am a prayer. May everybody be happy. May everybody be healthy. May everybody be free from pain. May everybody be free from sorrow. May we be the healing cure beyond every greed and lure. Thank you, sir.
Thank you. Thank you, Senthil sir. Now I call upon our IMA AMS chairman, Dr. Rajesh Babu sir. Welcome, Dr. Rajesh Babu sir. Dr. Rajesh Babu sir is senior consultant, neurosurgeon, and head of the department in Ganga Hospital, Coimbatore. Raj is the former president of IMA Coimbatore and currently chairman organ donation committee of IMA TNSP. May I request our chairman sir, Rajesh Babu sir, for the welcome address.
Good afternoon, everybody. It is a great pleasure in welcoming our president, Dr. Abul Hassan sir, for this program, and I welcome the state secretary, the state finance secretary, and Dr. Gunasegaran sir, our senior vice president sir, and the president-elect, Dr. Sengotuvan sir and Dr. Sridhar sir, and the past president, Dr. Sandamil Pari sir. I also welcome all the speakers and the panelists for this program. Actually, in the IMA AMS, the main aim of conducting the CME is because each and there are a lot of the health days are coming. For each and every day, we can conduct a program, but we are not doing it because it will crowd in the thing, and that's why we are joined together all the three programs. Even even in this month, we are having the World Kidney Day. Also, we are having the World Purple Day. One epilepsy program day also is there. Like that, so many days are coming, but we are not able to conduct the programs for all the things. And today we are concentrating mainly on the World Glaucoma Day and the sleep disorders, sleep day, and the World Tuberculosis Day. These 3 days we combine together, and we wanted to give for our audience what are the recent trends. And actually, the central headquarters IMA has requested all the branches throughout the country to conduct the glaucoma awareness program and also the glaucoma meetings in each and every branch. I request all the branch presidents and secretaries to please conduct CMEs on glaucoma and also give an awareness program, and also do the checkup of for the glaucoma and eye screening for all the IMA members and their family members to clearly screen the things. And these are all the things I wanted to tell. And rest of the things, those who are not become the IMA, AMS members, the membership fee is only 1,000 rupees. I request all of you to become the member of the IMA, AMS, and also in the branches which are not having the AMS wing, I request the presidents and secretaries and treasurers to please start the new branches, new AMS chapters in their branches. And I welcome you all for this CME. Thank you, one and all.
Thank you, Chairman sir, for your wonderful ideas. So we'll do a lot of awareness program for the AMS membership campaign and start all the branches of the IMA AMS wing. Thank you, sir.
Sir, sorry for the interruption. There is someone is still.
Okay. So now I call upon our State President, Dr. K.M. Abul Hassan, sir, our President of IMA TNSB, for the presidential address. Over to Dr. Abul, sir.
Thank you very much, Dr. Jayaraman. Good evening, all my dear friends and all the leaders of IMA, starting with Dr. Sendimal Pari, Dr. Sengutwan, Dr. Sridhar, and Dr. Karthik Prabhu, our Secretary, and Dr. Gauri Shankar, Finance Secretary, and Dr. Gunasekharan, National Vice President, and all the office bearers of IMA AMS, Dr. Rajesh Babu, Sendil Kumar, and Jayaraman, and the faculties of today's webinar, starting from our moderators, our friends Dr. Nirmal, Dr. G. Tilakavadi, and Dr. Suresh, the speakers, Dr. Suhasini, Dr. Supraja, and Dr. Sanmukhpriya. I'm very happy that all of you are gathered here in the IMA AMS platform, commemorating 3 important days, that is World Glaucoma Day, World Sleep Day, and World TB Day. I always tell that AMS and CGP wings are spreading knowledge, make our people learning every day. You all know that learning is a continuous process. I'm very happy that the academic bursts are happening in AMS and CGP. Every month we are having wonderful talks so that we enrich our knowledge. Yesterday I was reading a book by Dr. Virchow. Virchow, you know that Virchow's node and Virchow's triad, one of the very popular pathologists of those times in 1840, 1850 and all. In his book, he had published one letter. He wrote to his father. He was writing to his father about his ignorance. He says, it is how much and how painful it is to have gaps in my knowledge. So it makes me not to stand still in any branch of medicine. So he wanted to become anatomist. Again, he wanted to become a physiologist. But later he became a pathologist, well-known pathologist, and a forefather of, renowned as a forefather of pathology. So how important he, at that time itself, we realized that there were a lot of things to know. Again, I would like to mention another incident that in one of our conference, I was talking to a faculty who addressed the conference with a very advanced technique of our time, our advanced, allopathy medicine. One of the important milestone development, that is the robotic surgery. So he gave the talk and came down and he was talking to me. That time during the chat, I was mentioning that I have the skill of intubating a patient. Even a awake patient I can intubate. He was so surprised. He told me that it is a job of the anesthetist to do the endotracheal intubation. No, I said it is a life-saving method. It is for every surgeon or physician, every doctor to know the technique so that he can save the patient. Immediately he said, it's a great thing I came to know today. Today, from tomorrow onwards, I will learn intubation. Though I am a very skillful person of robotic surgery, so far I have not learned this intubation. So even at this age of 64, 65, I think it is my duty to know that very important life-saving technique. Like that, there are so much we are yet to know. There are so much we are yet to learn. So our mind is always should be in pursuit of knowledge. And I am very happy that IMA TNSB two important wings, that AMS and CGP, giving so much opportunities for people to know. These seminars are not only for the credit point. There are very, very important topics today. Probably these topics are so specialized ones, but it's very important for everyone to know. That's why I believe this seminar will be very much useful to all of you. So I wish all the delegates have a wonderful time and thank all the faculties and AIMS for organizing this wonderful webinar today. Thank you very much. Over to you, Dr. Jairam.
Thank you, President, sir. Definitely we'll follow all your advice regarding our IMA progression. The IMA is rising, so definitely we'll do all good things, sir. Thank you very much, sir. So next I'll give my secretary's report. I'm Dr. S. Jayaraman, Secretary of IMA TNSB. This is our team, our chairman, Dr. B. Rajesh Babu, sir, and myself, secretary, and joint secretary is Dr. Adar Chandra Kumar, sir. Thank you very much, President, sir, for this post to doing a lot of awareness activity among our own colleagues, sir. So we connected the World Cancer Day awareness activity on February 4th. I did my lung cancer awareness video for the our own colleagues as well as the general public to commemorate World Cancer Day on February 4th. So we connected the second webinar of our IMA AMS to commemorate World Cancer Day. A lot of faculties participated and all the medical oncologists, surgical oncologists, and the radiation oncologists participated, and more than 400 people participated in the online our webinar program. So it was very useful for all our members. And in the month of February 12th, to commemorate International Epilepsy Day, our chairman, Dr. V. Rajesh Babu, sir, did the awareness session for the Cholamandalam MS General Insurance Company people in Coimbatore. And IMA AMS Coimbatore, along with the NSS unit of Avinasalingam Home Science College, they did the anemia awareness program at Madambatti village on February 13th to create a lot of awareness about anemia and all. And our chairman did the web CME. One of the important topic is the clinical management of acute ischemic stroke in the web CME. A lot of people are benefited. And Coimbatore branch IMA AMS chairman, Dr. Balamurugan sir, did the presentation in the Diabetes Club of Dindigul. The topic of presentation was future insulins. So this was a very, very effective thing. And our national honorary secretary, Dr. Srirang Akbari sir, visited the Coimbatore, and our chairman, Rajesh Babu sir, honored with the sandal garlanding to our Srirang Akbari sir. Sir was the national secretary of IMA headquarters, Hyderabad. So this was a very great event on 24/2. And I participated on behalf of the IMA AMS as a guest of honor in the NAM branch of Chennai. So I sensitized all the members to enroll in the AMS and encouraged to start the AMS wing of the NAM branch. So Nanganallur, Alandur, Arambakam, and Madipakam branch on 24/2. So this is our own, my own branch, Chennai Villivakkam Ayanapuram branch. To commemorate World Cancer Day, we did the CME program, physical program on 25th February. This is the IMA AMS of Chennai Villivakkam Ayanapuram branch. So more than 60 people, doctors participated, and all the cancer leading specialists, Dr. Preeti and Dr. Ashwin took part in that, and we did a wonderful program on radiation and surgical oncology. And again, Dr. Balamurugan sir from the IMA AMS Coimbatore delivered a lecture awareness topic. There is a Facebook live program about the hypertension awareness on 26th February. And in Coimbatore, this is the 100th year centenary program of the IMS AMS wing of Coimbatore branch. Did the lung cancer awareness program on 28th February. So our chairman Rajesh Babu sir and the president of Coimbatore IMA, Priya Karthik ma'am, and other leaders of IMA participated. And a lot of discussions on bone marrow transplantation, immuno-oncology, breast conservation topic were discussed in detail. This program was supported by the Royal Care Super Specialty Hospital Coimbatore. And this is again IMA Ambattur Avadi branch of Chennai participated. And this is the first program of IMA AMS of Ambattur Avadi. They did the program on the infertility. So I was the guest of honor, participated and inaugurated the Ambattur branch of the Academy of Medical Specialty, AMS wing in the Ambattur branch. So this is a handout book already we have released in several occasions. Our chairman Rajesh Babu sir told our aims increase the life membership of our IMA AMS to start the wings of AMS wing in all the branches, and we are trying to start the courses, workshop, and observership. The BLS is one of the Jeevan project of our president project, and we commonly do it with other branches also. We're trying to start the journal conferences, state conferences, and every meeting we have credit hours from TNMC 1 point, and we're going to release the AMS newsletter periodically. So our main aim is increase life membership. There is 1,000 rupees is a one-time life membership. I request all the members kindly join in the IMA AMS chapter. I request all the branch president secretaries to start the IMA AMS wing of your own branch and enroll more members and start the activities. So these are the courses we are trying to start very soon: ophthalmology, spine surgery, upper GI endoscopy, laparoscopy, rheumatology, oncology, endovascular pulmonology, thoracic oncology, intensive critical care in all the multi and super specialty hospitals in Chennai, Kovai, Madurai, and all the big cities for our own members. This is not accredited by the TNMC or National Medical Commission. This is our own IMA courses connected by the IMA headquarters, Hyderabad, and this thing. And masterclass and workshop, we are trying to do a lot of programs. So to commemorate the World Sleep Day in MGM Healthcare Chennai, we did a sleep masterclass, and course director from Jaipur, Dr. Shivani Swami, participated as a course director and inaugurated the sleep lab and did the PSG lecture and the panel discussion and quiz program under the director of course director, Dr. Shivani Swami. I was organizing chairperson that day. This was the some of the pictures during the time of sleep masterclass at MGM Healthcare Chennai. So, Madam Dr. Shivani Swami inaugurated sleep lab in MGM Healthcare. We did a panel discussion, multidisciplinary panel discussion was held, and a lot of sleep and sleep disorders were discussed in detail to commemorate World Sleep Day. And this picture shows the polysomnography and all. This is the gold standard study. You all know very well about that. We are planning to start the observership for our own members to train, to get the knowledge in the various hospitals as a member. We are planning to start journal conferences. The first kind of thing, we are planning it on 28/4 at Trichy. This will be the East Zone Conference of IMA AMS. So followed by, we are planning all the journal level. And finally, we have IMA AMS State Conference at Chennai in September 2024 also. And TNMC semi credit points we are getting regularly, monthly from TNMC with the 1 credit points. This is a 3 hours program. And AMS newsletter, we are trying to release the newsletter in a state council meeting. So coming 17th, we are going to release our newsletter with the presidents and our chairman and all. So this will be a very continuous support. And this is the BLS. This is a very dream project of our president, Dr. Abul Sir, Jeevan program. So along with the other team, we are going to perform various BLS course workshop in a college, school level for teachers, students, and general public. So with that view, I thank you very much for your patient listening. May I call upon our National Vice President, National President, Dr. R.V. Asokan, sir. I think sir is traveling. Sir may join at any time. I know the sir is here and all. May I request Dr. R.V. Asokan, sir? Are you here, sir? Yes, sir is traveling. Yesterday he called me. And I request the Honorary General Secretary of our IMA headquarters, Dr. Anil Kumar J. Nayak, sir. Both are traveling, I believe. Okay. May I request our National Vice President, R. Gunasegaran, sir, for the felicitation. Over to Gunasegaran, sir.
Good afternoon, everyone. Respected State President, Dr. Abul, and the Chairman of the AMS, Dr. Rajesh, the Secretary, AMS, Dr. Jayaraman, and all the AMS office bearers. Respected President-elect, Dr. Sengutuvan, Dr. Sridhar, if he is there, Dr. Karthik Prabhu, Dr. Gauri Sankar, and all the moderators, especially our Dr. Nirmal Frederick and other moderators, and all the faculty members, and the members who joined in this webinar. I am extremely thankful to the team IMA AMS for the invite and also conducting this 3 important CME program in connection with the respective days, especially the glaucoma, the sleep disorders, which includes the sleep apnea syndrome, obstructive sleep apnea syndrome may be dealt with, and also the TB field. Every member has to know every year what is going on in this field of medicine, especially in the glaucoma and the sleep and TB. So it is our duty to enlighten our members about on this subject on this special day. I congratulate the office bearers of AMA for organizing this wonderful program. Through this, I also invite on behalf of IMA AMS to welcome all of you for the East Zone IMA AMS conference at Trichy on 28th of April. Thank you very much. You have a wonderful day today. Thank you.
Thank you, National Vice President Gunasekharan sir. Definitely will participate in the East Zone Conference in Trichy on 24/8. Thank you very much, sir. Thank you, sir. May I request our IMA AMS Headquarters Chairman, Dr. Nomita Sivagupta, ma'am. I think, madam, yesterday I called. Madam is in Arunachal Pradesh traveling, I believe. Some network issues. Madam, join at any time. May I request our IMA AMS Honorary National Secretary, Dr. Srirang Abgari, sir. Dr. Srirang Abgari, sir. Okay. May I request our IMA State Honorary Secretary, Dr. Karthik Prabhu, sir, for the felicitation.
Yes, sir. Good afternoon, everybody. Most respected President, IMA Tamil Nadu State Branch, my fellow office bearers. Congratulations to everybody. I was in the passport office, so that's why I couldn't on the camera. I'm just outside. So this is a wonderful topic, well arranged, and because I feel sleep apnea is something which is very underdiagnosed. So you've taken steps to make it as a very important topic, which will be well useful for many of us. And of course, glaucoma and TB update is very important. I congratulate the AMS team for this wonderful meeting. Keep going, sir. All the best for your all endeavors. Thank you.
Thank you, Professor. I may request our State Finance Secretary, Gauri Sankar, sir.
Most respected President Dr. Abdul sir, Dr. Honorary Secretary Dr. Karthik Prabhu, immediate past President-elect Dr. Sengutuvan, and Dr. Sridhar sir, all the office bearers of AMS wing, Dr. Rajesh Babu sir, Dr. Jayaraman sir, and Adar Senthil Kumar sir, and all the eminent speakers and all the moderators, Dr. Nirmal Frederick sir, Telagudi madam, and Suresh sir. So the AMS chapter is doing, AMS wing is doing very well, and they are establishing branches all over Tamil Nadu, and they are encouraging all the branch presidents and secretaries to start the AMS chapter in a very big way. I hope all the branch presidents and secretaries will help you in making the AMS chapter happening in all the branches. Thank you for your efforts, Jayaraman sir. Hope Rajesh Babu sir is also doing a very good job. That's very congratulations, hearty congratulations that you are covering all the three things that's happening today. The one is glaucoma, sleep disorder, and also the tuberculosis. And you have selected all the eminent speakers in all the three fields. Congratulations and best wishes. Do well, sir. Thank you for the opportunity.
Thank you, Gauri sir. Thank you. May I request our immediate State Past President, Dr. T. Sendamal Pari, sir. I think sir is traveling, I believe. Okay. May I request our IMA TNSB President-elect 2024, Dr. P. Sengutuvan, sir.
Good afternoon to everybody. Respected President Dr. Abdul Hassan, Honorary Secretary Dr. Karthik Prabhu, and my brother Gauri Sankar, Academy of Medical Specialties, Dr. Rajesh Babu, Dr. Jayaraman, Adar Senthil Kumar, Honorary National Vice President Dr. Gunasekharan, and fellow office bearers. It is really a very good performance by the Academy of IMA Academic Platform, doing all the wonderful services to the participants. So it will be highly useful for them. And I request our Secretary, Dr. Jayaraman, to release all the webinars in a slide, or make it as a book copy so that it can be distributed to the conference during your state conference. It will be highly useful to all the people I congratulate all the speakers of the day and moderators of the day. Thank you, sir, for the opportunity. Thank you very much.
Thank you, Secretary, sir. We are planning to release the newsletter from AMS every state council meeting, sir. We are compiling all the speakers' slides, everything. We are going to write. We are getting write up to all the speakers and all. We are going to release periodically, sir. Thank you, sir. Thank you, sir.
Thank
May
you.
I
Thank you.
request President-elect 2025, Dr. B. Sridhar, sir. Sridhar, sir. I think sir is traveling, I believe. Okay. So with that, I thank you all the leaders for your felicitations. So we'll follow all your advice periodically. We'll update. So with this, we'll start our CME program. May I request Dr. Adar Sindil Kumar, please take over and start introducing the moderators and hand over mic to moderators. Over to Dr. Sindil Kumar. Shall I stop share screen?
Yes, sir.
Yeah.
நான் கிளம்புறேம்மா. மளிகை காசை கொடுத்துட்டியா?
I request everyone kindly mute. Yes, Sindil sir. Unmute your mic, sir. You are muted now. Unmute your mic. Yeah.
Sir, very warm greeting to all. I'm going to introduce the very good renowned speaker, Dr. Nirmal Frederick. He is the Chief Eye Surgeon, Nirmal Eye Hospital, Chennai. He is the member of Accreditation Committee, NABH. He is the President of Tamil Nadu Ophthalmic Association. He is the Chairman of the Insurance Committee, IMA-TNSB, and he is the advisor in the editorial board in various journals, is the executive committee member in the Ocular Trauma Society, and is the council member in various organizations. And is the founder president of Tambaram Ophthalmic Society, is the past honorary treasurer and the secretary and editor-in-chief in Tamil Nadu Ophthalmic Association. He is the member of management committee in All India Ophthalmic Association. He was the secretary chairman of the National Nursing Home Board in 2016 to 2020. He was the president of IMA Tambaram in 2022 to 2022. Next. He has given more than 1,500 lectures and presentations in national and international conferences. And he has published more than 45 publications. He released 12 books, and he is the author of the NABH Eye Care Standards and NABH Guidebook to the Eye Care. He is the chairman of NABH Eye Care Standards, and he has received over 30 awards, and he delivered various orations, which is most important being he received the IMA National President Appreciation Award in 2020, 21 and 22, 3 years consecutively, sir. We are very fortunate enough to have with us Dr. Nirmal Frederick, sir. Over to Dr. Nirmal Frederick.
Thank you, Dr. Sandil.
Sir, sir, screen sharing option, sir.
So thank you, Dr. Jayaraman, sir, and Dr. Sendil, respected President IMA Tamil Nadu, Dr. Abul, and senior members of IMA, including Dr. Gunashekaran, sir, National Vice President, and all the dignitaries and leaders of IMA. It's indeed a great pleasure to be part of this webinar. I thank the most dynamic AMS Secretary, Dr. Jayaraman, the Chairperson, Dr. Rajesh Prabhu, and Dr. Sendil for inviting me here. And it's indeed a great moment to be part of the World Glaucoma Week celebration. And can I have the screen sharing option?
Sindil, you can stop share screen, sir.
Yeah.
Stop, sir. Yes, sir. Yes, sir.
Yeah, thank you. I think still it says host disabled participant screen sharing.
Arvind, make Nirmal sir as a co-host.
Name, sir?
Arvind, Nirmal sir, make a
Okay,
Nirmal
okay,
sir
sir.
as a
Okay, sir.
co-host.
Okay, sir.
Yeah.
And so I thank all of you for
Arvind, make Nirmal sir as a
Done,
co-host.
sir. Done, sir.
Yeah. Sir, now you can share your screen, sir.
Yeah. Thank you so much. my screen visible?
Yes, sir.
Yeah, thank you. It's indeed my great pleasure to be part of this webinar to commemorate the World Glaucoma Week. And as you all know, every year we commemorate this World Glaucoma Week through the World Glaucoma Association during the second week of March. And this year, the theme is Uniting for a Glaucoma-Free World. So I thank IMA and its leadership for uniting for a glaucoma-free world. And it's a good initiative for uniting everyone to combat this important public health problem. So why this collaboration? As a member of Glaucoma Society of India, I think GSI has collaborated with our Indian Medical Association at the national level. Basically, is a big impact on healthcare because of glaucoma. And so this is the global data, 8% of the world blindness is because of glaucoma. It sounds a bit little, only 8%, but the significant is more. So this is the area where we need to concentrate. Glaucoma is the #1 cause of preventable, irreversible blindness, not the reversible type, irreversible blindness. So therein lies the significance. So if glaucoma affects one vision so much, why are people not started on treatment, or why do they don't come? Basically because it is underdiagnosed, undiagnosed, and many people are there living with glaucoma, but without being aware because there is not much of symptoms. I will not go into the details. My colleague, Dr. Suhasini, will be dealing with that. But why we as doctors, physicians, specialists in other fields have to join hands to collaborate in ensuring that glaucoma is detected, because by the time the visual field loss is detected, it is too late. And this is where, as healthcare professionals, we all need to collaborate and come together. And this is also the reason why this disease is called as silent thief of sight. So what is the impact? So when the nerve is damaged, it progressively leads to loss of vision, not only the vision, but also the contrast sensitivity. And these are some of the early signs. And so the more advanced the glaucoma is and the field loss is more. And there are other defects also which happens, like driving difficulties. So the patient may not say only defective vision. They may subtly tell you in the history that he or she has driving difficulties, has been bumping with the walls or meeting with frequent accidents, has some near vision problem or difficulty in detecting the color changes, all those things. So they may present to you as a general practitioner, as a specialist in other field, with so many other complaints. So not perceiving colors, not able to do their computer activities, or with history of fall. The fall is very important because it not only affects the vision, but also leads to poor quality of life. And there are other symptoms like mental health burden. This is becoming one major issue because most of the glaucoma patients are depressed as well as anxious about their disease. And this is the reason glaucoma also has a road safety issues. They may end up with accidents, and the end of life, many of these patients are blind in either both eyes or one eye. So this being the significance, and fortunately, this blindness is preventable if it is detected and treated early. And this is where we are here to see what we all can do as a medical professional, as a socially responsible professional. So the numbers, so 95.4 million might be affected in the next 5 to 6 years. So these are not mere numbers. They could be one of our patients, one of our family members, one of among ourselves. So that is the reason GSI has pushed forward this initiative with collaboration with IMA. And we are also having a lot of awareness program about glaucoma this week and the entire month. I request all our members, both IMA and non-IMA medical professionals, to join hands to help combat this disease and important social issues. So what can be done? One is you can help us in optimizing the detection and screening protocols. If you come across patients, there are a lot of new methodology available, including artificial intelligence technology, to detect the disease at a much earlier stage. There are cost-effective screening programs, so with smartphones available everywhere. So a lot of cost-effective glaucoma screening programs have come up. Glaucoma treatment, there's a wide option now, including invasive as well as non-invasive therapy, and a lot of good therapeutics, new therapeutics like stem cell research also come up. So my colleague will update you all this. And apart from that, there are certain hidden challenges where you can really help the glaucoma surgeons as well as the ophthalmologists to help treating the patient. So there is a wide spectrum of treatment, and most important is the systemic health. Many of these patients have diabetes, hypertension, and certain connective tissue disorders may present with you with all this problem with medication or without medications. So you also have to be aware as a medical professional the potential side effect of medication, both systemic as well as ophthalmic medication. And also we are also aware of the cost potential and also how we can change the lifestyle with our own personalized and customized algorithm. So since it's being a big public health problem as well as a social problem, it's important that we join hands and start in the glaucoma awareness initiatives. I'm happy to introduce my colleague, Dr. Suhasini, who's the glaucoma specialist and a consultant at MGM Healthcare, working with Dr. Jayaraman. She has finished her MBBS from Stanley Medical College and post-graduation. She's an expert in diagnosis of ophthalmic disease disorders, especially glaucoma and the associated systemic disorders. Her keen interest lies in corneal disease and glaucoma management. She has worked with me in Tamil Nadu Journal of Ophthalmology and has been known for her precision and commitment to delivering exceptional patient care. So once again, I thank Dr. Jayaraman and team for inviting me here. It's a pleasure to introduce my colleague, Suhasini, and request her to talk to us about glaucoma and its implications. Over to you, Dr. Suhasini.
Suhasini ma'am, shall I share screen from my side or?
Sir, yes, sir, if you can.
Okay, I will share your screen.
Good afternoon, sir.
Yes,
Thank you to Dr. Nirmal Frederick, sir. Thank you so much for the introduction. I believe sir has covered most of the important points that I was intending to talk about, which is why glaucoma is important and the importance of glaucoma and why we are celebrating or commemorating Glaucoma Awareness Week, which is during the second week of March this year, which falls between 10th to 16th of March 2024, is because glaucoma is the primary or the leading cause of reversible blindness. So I will just touch upon basics of glaucoma pathology, diagnosis, and management. I would urge one and all to urge patients that are known to us, refer them to an ophthalmologist whenever possible. If there are any of the high-risk factors that we note, especially like family disease, family history, etc., to undergo screening for glaucoma and urge on follow-up and regular monitoring of the disease if diagnosed. Glaucoma Awareness Week is this week, which is between March 10th and 16th, 2024. The World Glaucoma Association with the World Global Glaucoma Network have launched this year's theme of Uniting for a Glaucoma-Free World. Next slide, please. So why do we talk about glaucoma at all? Why the importance given to this particular disease is because of the prevalence and the disease burden of this particular disease. It is the second leading cause of blindness worldwide, second only to cataract, which is reversible, whereas it is the first leading cause of irreversible blindness, as Dr. Nirmal Frederick mentioned before. The global prevalence of which has been noted according to an American Academy of Ophthalmology study is about 3.54% of population between the age of 40 to 80, which seems like a small number, but it is about 64.3 million people worldwide. And this number is estimated to increase to 111.8 million by the year 2040. Hence, the importance given to glaucoma and its implication. Coming to epidemiology, primary open-angle glaucoma has highest prevalence in the African countries, and Africans and African American population is at a higher risk worldwide. Whereas the Asian population is at a higher risk of primary angle closure glaucoma. Next slide, please. Glaucoma, the next slide, please. Glaucoma, the word originates from the mid 17th century. So somebody back then identified that somebody suffering from a particular disease and blindness had gray or green haze in the pupillary area, and in Latin or Greek, glaucos stood for or implied bluish or greenish hue. And in the days of Hippocrates, blindness which occurred in the elderly was called glaucosis. Eventually, Dr. Bannister established a connection between the increase in the intraocular tension of the eyeball and glaucoma. Eventually, when von Helmholtz in the 1850 invented the ophthalmoscope, we were able to diagnose glaucomatous changes in the fundus. Donders in 1862 eventually coined the term glaucoma simplex and connected high intraocular pressure to lead to blindness. Further invention of the tonometer, perimeter, uses of medication like cocaine helped in further establishing diagnostics and therapeutics of glaucoma. The first effective surgical treatment of glaucoma was an iridectomy done by von Graffi in 1856, and the treatment by therapeutics by medication started in 1875 with the discovery of pilocarpine. Next slide, please. Glaucoma is known as the silent thief of sight. It is called the silent thief of sight because it is asymptomatic and absolutely painless. So up till the advanced stages of glaucoma and the severe loss of vision, by which time patients have only tubular or tunnel vision, is when unfortunately most patients come to the eye clinic. And like I said, this is an irreversible painless visual loss. And at that point, there is not much we can do for the patient. So glaucoma signifies a group of diseases that leads to damage of the optic nerve. The major risk factor here noted is increase in intraocular pressures. Next slide, please. There are different types of glaucoma, broadly classified as open angle glaucoma, primary and secondary, angle closure glaucoma, again primary, secondary, normal tension glaucoma, wherein the pressures are normal, but the optic nerve head changes continue to occur. Secondary glaucoma caused because of other issues, both systemic as well as ocular, congenital glaucoma and infantile glaucoma. And there is a separate entity called ocular hypertensives, wherein there is increase in the intraocular pressure without changes in the nerve, which need not be treated. Next slide, please. So what are the risk factors for glaucoma? The primary risk factors which has been proven, and there is enough evidence that reducing intraocular pressure and can lead to prevention of progression of glaucoma, and hence the most important risk factor noted in glaucoma is ocular hypertension or increased IOP, which is intraocular pressure. Family history and genetics play a very major role. So if there is family history, screening is compulsory and mandatory. For the genetic, there are congenital glaucoma and infantile glaucoma have certain strong genetic markers which are identified. Ethnicity, as I said, African American population, Africans per se have high risk of primary open angle glaucoma. Diet, there is no direct correlation, but it has been found that there is certain foods like caffeine, for instance, which can cause IOP spikes in those who have predisposition to developing glaucomas. Secondary glaucomas have multiple other risk factors like diabetic retinopathy, one of the most important causes of secondary glaucoma, central retinal, all retinal artery occlusion, vein occlusions, ocular trauma, which can cause angle recession for the glaucoma. There are further anatomical variants which can cause glaucoma, and uveitic glaucoma or inflammatory diseases causing glaucoma. Next slide, please. So pathophysiology. Here, the established finding that we have found is that there is increase in the intraocular pressure, and this pressure causes mechanical stress upon the nerve fiber layer, which is the continuation of the retinal ganglion cell, which exits through the lamina cribrosa at the posterior aspect of the fundus, the eye, and continues at the optic nerve. At the junction of the or at the optic nerve head, there is pressure and mechanical stress because of increase in the intraocular tension, and this leads to irreversible retinal ganglion cell death. In case of open angle glaucoma, there is increased resistance at the level of the trabecular meshwork, whereas in angle closure glaucoma, the access to the drainage pathways, which is either the trabecular meshwork or the uveoscleral outflow, both are obstructed. Next slide, please. Coming to diagnosis, here I cannot stress the importance of screening. Screening is integral to glaucoma because it is an asymptomatic disease in most cases. Only one fraction of patients, which is either advanced stages of glaucoma where there is only tunnel vision, or in case of an acute angle closure attack, is when the patient themselves come to the ophthalmologist and complain of some visual issues or ocular issues. Otherwise, prima facie, glaucoma is a disease which is picked up on regular screening. Hence, the importance of screening especially after the age of 40. One must undergo a screening. In case of a stronger family history, even sooner, and definite follow-up in case of strong family history and in case of suspicious glaucomatous patients. So how do we do the diagnosis? First is by tonometry. Tonometry essentially means measurement of intraocular tension. This is done by various methods. Initially, we used to use shots in the early days. Now that is out of vogue. We either use something called non-contact tonometry, which feels like a small puff of air in the eye to measure the pressures, or the gold standard, which is a Goldman's applanation tonometry. The normal intraocular pressure is between 11 and 21 millimeters of mercury. Next step is to assess the anterior chamber angle assessment, which is either done by gonioscopy, or in today's day and age, we have high-tech instruments like the anterior segment OCT, where we can visualize the anterior chamber angles in real time. But nothing fails the age-old techniques of gonioscopy and actually visualizing the angles. Gonioscopy is also helpful in both diagnosis as well as therapeutic, wherein we use selective argon laser trabeculoplasty, wherein we use wherein we use lasers to treat the same. Dilated fundus examination is very important. Here we visualize the optic nerve head, and on follow-up, serial analysis shows progression of disease. Pachymetry, wherein we measure the central corneal thickness and appropriate the IOP, the intraocular tension measurements, appropriately to the central corneal thickness which is measured. Visual field testing, because glaucoma follows a very specific pattern of visual field loss. Visual field testing is imperative in both diagnosis as well as in follow-ups. Worsening of visual field testing signifies that the management of glaucoma is inadequate or needs further stepping up of medication or additional treatment by means of laser or by a surgical intervention. Finally, a very important tool that we use these days is the assessment of retinal nerve fiber layer thickness. During the times when this OCT, very critical tool which was not available, we had to go by our own assessment of the neuroretinal rim thickness and thinning of the neuroretinal rim on serial fundus examinations, which was very arbitrary and subjective. The RNFL thickness gives us a quantitative measurement of the retinal nerve fiber layer thickness, and technology and machine learning and artificial intelligence enables us to both analyze, compare, and have a trend analysis of how the patient's serial OCTs are, and how this patient would trend if this patient continued to trend along with the current management or without. So this is a very important tool which has changed the way we treat glaucoma these days. Next slide, please. So this is a typical optic disc change. Of course, the left side shows the normal optic disc, wherein the optic cup to disc ratio is about 0.3 to 0.4, whereas on the right side is a optic nerve in case of an advanced glaucomatous disc, where the cup enlarges and has occupied almost the entire disc area, wherein the neuroretinal rim is almost absent. Next slide, please. Next slide, please. Thank you. The visual field defects, like I mentioned, are very typical, again, when it comes to glaucoma. It starts with enlargement. First, it starts with generalized peripheral constriction of field, which is very difficult to map on a visual field chart. But there is a significant increase in the blind spot next, which further develops into a centrocecal scotoma, develops into a paracentral scotoma. The central and the paracentral scotoma merge to form a germs or a semi spares the macular area. So this macular area is spared almost towards till the end of the advanced stages of glaucoma, and hence preserving that tunnel vision that patients are left with at the advanced stages. There is a superior paracentral scotoma, which corresponds to inferior retinal nerve fiber layer thickness loss, which occurs initially to begin with. Further, it becomes a bi or a biparacentral scotoma, or almost a ring scotoma, which is characterized by a Ronay's nasal step. And finally, the patient is only left with a tunnel vision. Next slide, please. This is what a visual field test looks like on a printed assessment. This is a patient who has lost essentially almost the superior half of the vision to glaucoma. There are multiple factors where what we look at here, which is reliability factors, the media opacities, blind spot fixations, etc. Next slide, please. So treatment of glaucoma is primarily IOP control, which is the only major modifiable risk factor. The other risk factors are not modifiable, and hence we optimize a target IOP for a particular patient. Target IOP is the pressure at which the disease progression is arrested, where we protect the visual field from progressing, and this preserves the quality of life and minimize side effects with the medication. And hence, to achieve target IOP, routine eye examination is mandatory. Further, it is important that the target IOP be maintained. It is very difficult to ensure compliance in patients who have glaucoma, and hence it is important for us to counsel the patients on the importance of glaucoma medication to be taken without fail every single day, and stressing the importance of that one drop, especially in the early stages of disease, can help in that one drop at bedtime usually during the early stages goes such a long way in preventing and preserving the visual fields for a really long time. Next slide, please. So the commonly used medications are first prostaglandin analogs like travoprost and bimatoprost. Prostaglandin analogs are usually the first line drugs that we use because of their side effect profile being so safe, and the amount of IOP reduction that they cause in except for in conditions like uveitic glaucoma wherein it cannot be used. The only drawback is the price range that the PG analogs come at, and the advantage of prostaglandin analogs is also compliance is good because of once daily dosing. Second is beta receptor antagonists, which we have read about ever since probably we did our MBBS days. Timolol being age old, but gold again in patients in whom it is not contraindicated. Timolol still holds good. Alpha-2 adrenergic agonists like brimonidine, which have also shown some neuroprotective effects, help in reduction of IOP, but also have neuroprotection and hence are frequently used. Myotics, in case of, sorry for the spelling, myotics like pilocarpine still are used as a stopgap between performing a peripheral iridectomy or a drainage procedure, and hence its importance. Carbonic anhydrase inhibitors are used both topically as dorzolamide and as acetazolamide orally in case of postoperative IOP spikes, reduction in pressures in case of very high or absolute glaucomas, also to reduce pressures immediately before performing an intervention or surgical treatment. Next slide, please. Lasers, commonly performed laser is an Nd:YAG, an office procedure wherein we just make a small bypass opening to drain the aqueous from the posterior chamber to the anterior chamber. This is both therapeutically used in case of an angle closure attack to break an angle closure attack, or prophylactic in case of a narrow angle glaucoma, which we suspect can go in for an angle closure attack at any given point of time. So we do prophylactic iridotomies to both eyes using a double pulsed Nd:YAG. Argon laser trabeculoplasties are selectively used and applied to improve the outflow through the trabecular meshwork. Next slide, please. And finally, we come to surgery, trabeculectomy with or without chemotherapeutics to reduce the chance of fibrosis. So chemotherapeutics like 5-fluorouracil, mitomycin C, and Ologen implants are used. Usually combined with cataract surgery. Usually trabeculectomy is performed with cataract surgery, which also allows the iris lens diaphragm to fall backwards, also improving and creating the drainage pathway. Essentially, in trabeculectomy, what we do is we create an artificial pathway by passing the trabecular meshwork to form a bleb with just the conjunctiva over the superior aspect of the above the superior limbus to form a fluid reservoir, and then this gets absorbed via the uveoscleral outflow and otherwise. Additionally, we have something called now the micro-incision glaucoma surgery, wherein we also can implant various glaucoma drainage devices. Some drainage devices are valved, some are non-valved, some are micro-incision, like the eye stent. The others are Ahmed valves, Bard valves. And the results of trabeculectomy along with drainage implants are quite good, especially with the Ahmed valve, which is a valved shunt, provides really good results, especially in case of glaucoma patients who have been through maximum medical therapy and still have progression of disease. These give really good results. The valved implants provide again advantage because they cause they avoid the sudden drop in IOP, and hence they avoid the rapid fluctuations in the high and low IOPs, and can help us to kind of titrate the IOP and prevent choroidal detachments and hypotony of the eye and the complications resulting from that. That's about it. Thank you. Last slide. Thank you.
Thank you, Dr. Suhasini. That was a wide coverage on the entire topic, right from history to the modern day management, micro-incision invasive glaucoma surgery. Any questions from the audience?
This is Dr. Jayaraman, sir. Jayaraman speaking. Regarding glaucoma management, is it a curable or controllable disease? Suppose if a cataract, this is a curable. If once you put the intraocular lens, this is a completely curable disease, cataract. Likewise, glaucoma is the curable or controllable disease.
You like to take up, Dr. Suhasini?
Yes, sir. Yes, sir. It is not a curable disease. It is a controllable disease, like most chronic diseases that we face, like diabetes, hypertension. Most patients need to be on anti-glaucoma medication lifelong, unless they go for procedures like trabeculectomy. In some patients, only just going through surgical procedures, wherein it is got to do with, it is actually sometimes also curable, wherein if it is lens-induced glaucoma, then probably a cataract surgery will just be curative for them. But in most cases, it is a controllable disease with the medication, sir.
Yeah. Another question from Dr. Treatment of congenital glaucoma. Treatment
Yes.
of congenital glaucoma.
Treatment of congenital glaucoma invariably is surgical, sir. So identification of ophthalmos or congenital glaucoma and implantation of combined surgery, again trabeculectomy with Ologen implants or with valved procedures are the mainstay even today, sir. And
If I can intervene,
yes,
for congenital glaucoma, the treatment is essentially surgical,
surgical.
and it
Yes.
depends on the extent of congenital damage that has happened with the trabecular meshwork. If there's only a membrane, it's a curable condition.
Yes, sir.
And if there is a derangement of the trabecular meshwork and it is quite extensive, then we need to resort to other filtering surgeries like trabeculectomy or set-on or valvular surgeries. And so basically it depends on the type of congenital glaucoma and at the stage at which it is diagnosed.
Okay, fine. Is there any?
Yeah.
Nandamurthy sir.
Yes,
Yeah,
sir.
I have a basic question. So, patient with glaucoma driving license issue பண்ணலாமா for heavy vehicle?
Depends on the damage visual field available. So if it is a tubular vision and it's restricted to less than 20-degree field in the best eye, then we don't allow them to drive. For commercial driving, it is a restriction. They will not be issued a driving license. For personal driving, there has to be a visual field of more than 20-degree in the best eye. Eye donation as such, we are using only the cornea retrieved from the cadaver. So glaucoma patient who has good cornea can donate their eyes. There's no contraindication for that.
Thank you. Thank you.
Thank you, sir. So if there are no questions, I would like to thank the IMA leadership for taking up this initiative of World Glaucoma Week awareness program. I will also convey this message to the Glaucoma Society of India about the wonderful work done by the IMA TNSB and the AMS chapter, and particularly the chairperson and secretary, Dr. Jayaraman. And thank you, Senthil sir, for inviting us. And thank you, Suhasini, for that wonderful talk, giving a bird's eye view of glaucoma for this elite audience. Thank you so much.
Thank you, sir. Thank you for the opportunity, sir.
So thank you very much, Professor Nirmal Frederick sir, for the wonderful moderation, and Dr. Suhasini for this wonderful insight into the glaucoma diagnosis and management to commemorate this World Glaucoma Day. So thank you very much, stalwarts of ophthalmologists, Dr. Nirmal sir and Suhasini ma'am. So thank you very much. So we'll move on to the next session, World Sleep Day session. So for which may call upon moderator Dr. G. Tilakvati ma'am. Tilakvati ma'am is MBBS MD DTCD. Madam with MBBS from Sri Ramachandra Institute of Medical Sciences, Porur, and Madam did DTCD and MD Chest Medicine from the Institute of Thoracic Medicine, Madras Medical College. And currently, Madam is the senior consultant and head of the Department of Respiratory Medicine, Interventional Pulmonology, and Sleep Medicine in Vijaya Group of Hospitals. So, Madam has a special interest in interventional pulmonology, sleep medicine, fungal infections of the lung carcinoma, an extensive experience in COVID patient management, and Madam was teaching very good clinician, academician, and very good orator. Madam has a professional experience in as assistant professor in TB and chest disease for 5 years, associate professor of TB and chest disease 3 years, and currently is a consultant in Apollo Clinic and Vijaya Group of Hospitals. And Madam is the HOD, so very well orator. So may I request Dr. Tilakvati ma'am, please take over and introduce the topic and the speaker. Over to Dr. Tilakvati ma'am.
Thank you so much for the wonderful introduction, Dr. Jayaraman, a good friend of mine. Good afternoon to one and all who all have logged in here. Thanks for joining here. Dr. Jayaraman's enthusiasm and energy is truly inspiring and addictive. So many meetings back to back he arranges, and his involvement in sleep is so much that I'm so much truly inspired by this. It is indeed a pleasure and honor to be part of this elite academic initiative, where doctors want to be academically updated. I'm so happy to be in this platform. Thank you so much for the invite. So going on to the topic, to commemorate with the World Sleep Day, we all might think that sleep seems to be a simple aspect of our life, but it is the more complex one that we won't believe that it can lead to so many problems if you have lack of sleep. So sleeplessness, snoring, OSA can cause life-threatening illness, such as refractory hypertension, cardiovascular illness, hypoxemia, metabolic syndrome, weight gain, and the most ignored part of our health is sleep. Just like how glaucoma, they said that it is not diagnosed early and presents late. The same thing applies to sleep also. Most of the symptoms are non-specific, and there is no one clinching point to say that you have a sleep disorder. And people refuse to come early for treatment, and it often diagnosed with lots of comorbidities and at a later stage. So it is a simple, preventable part of health. The theme for 2024 World Sleep Day is Sleep Equity for Global Health. Imagine they want to improve the global health by ensuring that the sleep is adequate for all individuals across the globe uniformly. So for implementing and understanding this, we have an eminent speaker, Dr. Supraja. It is indeed my pleasure to introduce Dr. Supraja. She is a lead pulmonologist and director at Medway Institute of Pulmonology, Chennai. Other than being an interventional pulmonologist, she has a passion for pulmonary rehabilitation and sleep. Apart from this, she also is interested in various trials. She's pursuing her PhD. Her enthusiasm is unmatchable. If I have to introduce her, I think it will take her degree and other things. It will take another half an hour. She has so much jewels in her crown. And she's not only that, she's part of a non-government NGO which helps spread knowledge to signs of underprivileged children. Imagine, she's a true all-rounder, and you cannot ask for a much better speaker in this platform for sleep. I welcome Dr. Supraja. The stage is yours. Please go ahead.
Good afternoon, one and all. And encouragement. I thank IMA for giving this wonderful opportunity. And with the sleep celebrated as World Sleep Month on March 17, I think we should know good sleep is something that we cannot, pay for. And the complications of sleep is something that we
Yeah. Subraham, shall I share your screen? Okay. Yeah, is it visible, ma'am? Subraham, ma'am, is it visible your screen presentation?
Okay, sir.
Yes.
Yeah. So go to
Tilakam, ma'am, the slide is visible, ma'am. Tilakam, ma'am, slide is visible.
Yes, it is visible. Yes.
Yeah, Supraja, ma'am.
She's muted. Dr. Supraja.
So to begin with, the overview, we look at what is a burden. What is the burden when you don't sleep? That is the problem. And what is the pathology of how we can have a sleep disorder? What are the symptoms and what are the diagnostic tests that are available in the country right now? The treatment of when we refer to a sleep specialist. Next slide. So 30% of your adult life, there's something called as the Golden 8 rule, which is 8 hours of sleep, 8 hours of work, and 8 hours of milk. So if you do not give that, there is to a lot of metabolic disorders and cognitive dysfunction. Which is cessation or stopping of airflow for more than 10 seconds with continued chest and abdominal effort. and OSAS remains significantly under-recognized and under-diagnosed. Now, a lot of us snore, kids snore, adults snore, and the most common perception is you snore when you're sleeping well. But over the years, we have realized, is this really abnormal? So this is where the
Oh.
Yeah. Hello.
Yeah.
Yes, ma'am. Proceed, ma'am.
Yes. I'm not able to see the screen. Yes. Next slide, please, sir. So this is the Pickwickian picture which you saw there. Next. So the sleep disordered breathing is divided into multiple layers. The first is the habitual snorers. Like snoring is present on 3 or 7 days in a week. A lot of us snore, but in that, if you're having a apnea or a respiratory distress event, event, then we call it obstructive sleep. If it is associated with excessive daytime sleepiness, it is called OSA syndrome. And obesity ventilation is extreme obesity along with daytime hypercapnia and hypoxemia and sleep disorder with exclusion of other causes of hypoventilation. These are multiple spectrum in sleep disorder. Next slide. Yeah. So the world is 1 billion people in the world population between the age of 39
Puraja ma'am, your voice is not audible here.
was in 25% of males, and NHI of more than 50 was in the Indian scenario. If it's so the
Puraja, is it okay? Shall I move on to next?
so the pathophysiology. Next slide. So can you play the video, sir? So this is how obstructive sleep apnea happens. So somebody is going in deep sleep. Obviously, your muscles are going to relax. You're going to go into a little bit of hypotonia. The most important muscle is your genioglossus, which is supposed to hold it tight and air goes in comfortably. So in a normal person who is awake and who is breathing well, the air goes in into the trachea and then into the bronchioles comfortably without any obstruction. But however, if there is a adenoids or if there is a tonsils, that is when snoring can happen. This happens especially in children. In adults, during deep sleep, when the tongue falls back or if the muscles go in for a constriction, the airway lumen is narrowed. And that is exactly the space where your obstruction is going to happen and it's not going to allow your air to go inside. So sometimes we notice that there is a nocturnal hypoxia which is seen in some people. So giving just supplemental oxygen will not be sufficient because there is a huge obstruction which is happening in the upper airway. Next slide, please. Next slide. So whenever there is an obstruction, these people go in for a startled response and they wake up and then again they go back into sleep. So this happens in a subconscious level, so they do not wake up completely. And these episodes happen multiple times. So what are the problems of these apnea and hypoapnea? So one can be in terms of sleep fragmentation, hypoxemia, or an intra-negative thoracic pressure. So can you press the next button? All these things will lead to a sympathetic surge, hemodynamic effects on the CV system, oxidative stress, inflammation, endothelial dysfunction, and an endocrine dysfunction. So as a consequence of all this, there can be an increased sleepiness, neurocognitive side effects, cardiovascular side effects, and endocrinopathy. So as general physicians, this OSA patient does not walk into the clinic saying he has OSA. Usually they will present with the complications of obstructive sleep apnea, which we have to figure out. The previous hospital where I worked, cardiovascular complications was the most common presentation of OSA. If we picked it up and we treated this OSA, all these symptoms, especially the paradoxical rhythms, PSVTs, will abolish once you treat the OSA. Next slide. So what are the clinical features? You can divide them into daytime symptoms and nocturnal symptoms. Usually they will start with nocturnal symptoms in terms of snoring. The partner will start witnessing apnea where the patient stops breathing. There can be a restless movements of the legs, choking sensation, nocturnal polyuria, and dryness of mouth. These are the initial symptoms. Later on, because of recurrent obstruction in the sleep, they'll go in for excessive daytime sleepiness, generalized fatigue and tiredness, neurocognitive impairment. Sometimes erectile dysfunction can be one of the presenting features of OSA. I don't think anybody would have thought of this, but it is present in our current practice. Gastroesophageal reflux and morning headaches. Next slide. So what are the patterns? So in a obstructive sleep apnea, the level of the throat, or it can be at the level of the central system. So if it is at the level of the throat, we call it as obstructive, where the patient is able to breathe and there's a continued respiratory effort. If it is at the central level, the patient stops breathing, that is, he goes into an apnea. At the same time, the respiratory effort is also not there. That means there is no drive from the central neural system. Sometimes patients will present with both mixed obstructive and a central event when you will notice a pattern which is in middle. Next slide. What are the risk factors? Most common is metabolic causes like hypothyroid, obesity, increased neck circumference, or it can be structural like acromegaly, vocal cord paralysis, or head and neck masses can be there. And sedative use, alcoholic use, smoking, all these can be one of the risk factors. Next slide. So these are the pictures. I'm not intending to scare anybody here. So if there is any increase in the size of your palate, or if there is a uvular hypertrophy, or if there is a adenotonsillar hypertrophy, these are going to obstruct your upper airway. Sometimes it can be just a large tongue. Sometimes it can be retrognathia. This is the area of our oromaxillofacial surgeons, or in case of ENT, it can be a deviated nasal septum, which can be the cause of snoring and obstructive sleep apnea. Next slide. So how do we go about diagnosing it? Initially, the most important in the clinic is history taking. The easiest one is a stop bank questionnaire, as the it's a mnemonic. S stands for snoring, T stands for tired, O stands for observed. Anyone has observed you stop breathing, and P is increased blood pressure. Bang is BMI is more than 35, A is age more than 50, neck circumference more than 40 centimeters, and is it a male? So it's a very simple questionnaire. If the answer to any of this is more than 5, then it's a high risk. then you subject these people to a sleep study. If it's an intermediate risk, then you probe further. If it's a low risk, then we do not worry about them. The other detailed questionnaire is your Epworth sleepiness scale, where we ask about the parameters, whether they are sleepy during the day while sitting in a car, or immediately after a lunch, or when they are talking to somebody. So these are simple questions which we can ask in the clinic to identify the prediction of prevalence of obstructive sleep apnea. Next slide. So why do we have to know about this? What if somebody is snoring? What if somebody is having a disturbed sleep? We can divide the consequences into, it can be medical, it can be workplace related, it can be transport related, or it can be an economic consequence. Next slide. So medical consequences can be anything which we are seeing nowadays: an increase in the blood pressure, uncontrolled and continuous increase despite taking medications, and patient is following a strict rule. Most of our diabetic patients are obese, so we should have a high threshold of suspecting OSA in such patients. Recurrent heart failure, recurrent arrhythmias, stroke, because whenever there is a hypoxic event which is happening in the night, when all the systems are supposed to rest, especially your heart, your blood pressure, and your respiratory system, instead of resting, when they are overworking, it leads to an increased level of stress. So there is an increased inflammation. Now we all know that increased inflammation is the pathophysiology for most of the metabolic disorders that we are all seeing. So we need to suspect that. Next. Transport. A lot of people now are working in different shifts, and especially drivers, they are taking long drives because of the targets which are associated nowadays. So when sleep is, whenever there is a sleep impairment, even if a person is not having OSA, it's going to impair our alertness. So in obstructive sleep apnea, there can be a momentary few seconds when the patient can fall off asleep behind the wheels when they can encounter an accident. So they are a threat not only to themselves, but also to the society. There's a study in the US which has seen that more than 30% of their accidents were caused by drivers who were sleepy. Recently, we had an MLA lady who died because the driver slept behind the wheel. So these are one of the possibilities where we should be aware. When somebody says they are falling asleep even when they are driving, we should be aware and check them for obstructive sleep apnea. Next slide, please. Quality of life. Imagine if somebody is in a very high post and they sleep off during the board meeting. Somebody who is sitting in the cash collection cash collection counter, and he sleeps off. It's quite an embarrassment for people in the workplace. And we have seen a lot of people dozing off in conferences, not because they are dull, boring, but sometimes they also sleep off in on the dais. So it's very embarrassing. Also at home, people are not happy because they're not listening to whatever they're talking. Next slide. The economic consequences, the most important one, which all of us should know. The consequences of all the medical conditions which we have described, when the patient comes into the emergency, even though at that time it is not glaringly that it is OSA, the cost of any hospital admission is almost like 1 to 3 lakhs per admission nowadays. So the implications are huge unless we identify and treat them. Though the treatment cost is high, is what a lot of people are saying, but when you avoid them from admissions, you save them a lot of money in the future. Next slide, please. Next slide, yeah. So continue.
Shall I move next slide, Supraja? Dr. Supraja, can I move next slide? Supraja ma?
Next slide, sir.
Yeah.
So how do we go about with the testing? Next slide. So there are various levels of testing. We call them as polysomnography. So can you click it again? Where we are going to measure the neurological, cardiorespiratory, and the oxygen. So if you are going to measure all 4 parameters, then it is a type 1 or a type 2. The difference between type 1 and type 2 is when a technician is present. Otherwise, if you're going to see your neuro, cardio, respiratory and your muscle movement, wherein you will have around 32 leads onto the person, then we call it as type 1 study. If you're going to monitor only the cardiorespiratory, where you're going to look at snoring, thoracoabdominal movements, airflow and oximetry, then that is called as a type 3 study. Type 4 is a very simple or a watchpad study where we connect a simple bandage kind of thing onto the finger on multiple days, like 3 days or 5 days, and we constantly monitor the pattern of sleep, and it will give a interpreted value of your AHI. This is to be in patients who are not having any complications, but you're having a high suspicion of OSA, we can do it on them. So if you have multiple comorbidities, the best study is a level 1 study, because you need to look at the stages of sleep that the person is going into, and the cardiac parameters have to be looked into. If there are not many complications, no diabetes, no hypertension, no cardiac, then you can go in for a level 3 or a level 4. Next slide. So when you're looking at the polysomnography, the person is inhaling and exhaling, and then there is a period of apnea in the airflow. That is the second line. That is the airflow, which indicates the inhale and the exhale. And then the patient goes in for a apneic phase. Now, if you look below, there is a belt which will be there in the thorax, and there is a belt which will be there in the abdomen. If there is a continued effort, then that is an obstructive event. Next slide. Along with this, there will be a drop in your saturation. If there is a drop of more than 3%, then that is significant. Next slide, sir. Next slide. So keep pressing. Yeah. So if you look at hypoapnea is you just need not completely stop breathing, but you can just have a reduced breathing. Why should we know about this? Most of the females, when they come to us, they do not complain of snoring at all. In fact, some of them are very shy, they don't say. But in females, the most common pattern is a hypoapnea. But if they are going to have excessive daytime sleepiness, they're watching TV and they're just sitting in the sofa and dozing off, these people have to be suspected either for a OSA or a OHS, and they have to be tested with a level 1 study. Next slide, please. So there are various terms which we use, of which 2 are very important. Apnea is more than 10 seconds of obstruction to the breathing. Hypoapnea is more than 30% of obstruction for 10 seconds, and there is a 3% oxygen drop. So in a sleep study report, you will basically look at the AHI index and the RDI index. These are very important because AHI tells you the number of times the person has stopped breathing or has reduced effort at breathing. RDI is not only they are stopping breathing and reduced breathing, but they're also having an arousal. That means the patient is waking up from the sleep and then goes back into sleep. These are very important to understand and pick up obstructive sleep apnea. Next slide. The ODI is the oximetry, where the saturation drop, we are noting it. If it is more than 3% fall, it is very significant. Next slide, please. So if you doing a polysomnography, whether it is a level 3 or it's a level 1, you have to look at how much time the person has slept in bed. So in a level 3, we'll have only time lights out, lights on. Whereas in a level 1, we'll also have the efficient sleep time when the patient goes into N1 and the patient wakes up. So we'll have a effective sleep time, total sleep time. So the sleep efficiency should be 80%. That's when the PSG is called effective. And latency is the person has to fall asleep in less than 30 minutes. And REM should occur within the first 60 to 120 minutes. And they should spend considerable amount of time in N2 and N3. This is because that is when the body recovers, and all the repair mechanisms happen in the body. Also, they should have a dream phase, which is the REM phase, which is very important. Treatment for obstructive sleep apnea, why did they have OSA in the first place? They were all obese. So the first treatment is only going to be weight loss. And of course, if there is a nasal obstruction, you're going to correct it and help them. And avoid sedation, avoid smoking, and sleep hygiene. If you do not have a significant AHI, but the patient is complaining of significant excessive daytime sleepiness, you can tell them to change positions and then sleep. And avoid caffeine and reading in the bed. Next, please. So if you are doing a polysomnography, whether it's level 3 or level 1, so you're getting an AHI, which is less than 5, which is called mild. Then you go in for a simple asymptomatic lifestyle modification. You tell them to lose weight, exercise, and all that. Whereas if they are symptomatic, you will consider a CPAP therapy as well, even if the AHI is very less. If the AHI is 15 to 30, if they are symptomatic, along with lifestyle modification, CPAP therapy is a must. But if the patient is intolerant, ideally, I would recommend you to refer them to a sleep specialist, where we'll go on to next phase of BiPAP or surgery. If the AHI is very significant, more than 30, then we will consider definitely a CPAP therapy and a 100% lifestyle modification. Next slide. So, can you press it 4 more times? So there are various devices which we can see here. So they are called CPAP, BiPAP, APAP, VPAP, and ASV. CPAP is a manual device. Basically, it splints the airway. So in that you have a manual one and a auto CPAP. If you look at the profile, CPAP will give a continuous pressure. APAP will give a variable pressure based on the patient's level of obstruction. In the BiPAP, it's going to support with the 2 different pressures. That is an inspiratory pressure and an expiratory pressure. And ASV is a very special mode which is used in a specific group of cardiac patients, which I'm not going to discuss into. Next slide, please. So side effects of CPAP can be either interface related, pressure related, or it can be others. So interface related can be a air leak, which can happen, skin irritation, which is very uncomfortable for the patient, or in case of pressure related, it can be in the nose, mouth, or stomach. If they are having a rhinorrhea, then you can give a decongestant. If they are pressure, there can be pressure intolerance as well because of increased nasal resistance. That time you give a nasal decongestant. For dryness, you ask them to drink water, or if it is too dry, then use a humidifier. Aerophagy is a very common side effect. The others can be in the eye, dry eyes, you can give eye drops and pain in the eye, or it can be ears, can be because of noise related. Next slide. Next slide, sir. I have discussed the treatment aspect as well. So these are the various mask interfaces that are available in the market. The first one is your nasal mask. A is a nasal mask where it covers only the nose. B is oronasal where it is covering the nose and the mouth. C is a nasal pillow where it is like just a cushion which will cover the nose. And D is a oral mask. E is a face mask. And F is a helmet. Helmet we do not use. The E and F is usually used in the hospital setup when the patient becomes claustrophobic. Next slide. The other appliances where the dentist can involve is in mandibular advancement devices or tongue retaining devices, which are simple factors where the AHI is very less but the patient is symptomatic. Or this is the right hand side is the tennis ball t-shirts where it will help them in positional change, where they won't lie down on their back. Next slide. So please click on the video. So this is how the CPAP effectively works. So basically it has to splint the upper airway. So the air is going to be pushed and ensures that the tongue which falls back is being pushed away and then the stream is maintained. In such a manner, the oxygen is having a continuous delivery. So even if the patient was hypoxic during the night, if you give them a CPAP, their oxygen levels are going to be maintained because these patients are not hypoxic on room air. Next slide, please. So why do we have to treat? First thing, the partner feels happy because the partner is the one who brings them to us saying that they're snoring a lot.
patient sleeps really well. They'll sleep like a baby. They are fresh during the day. Their memory improves. Their pressure improves. Their cardiovascular complication improves. And the pulmonary hypertension and hypercapnia to a certain extent can be reversible. Next slide. So when do you have to refer a person to a sleep specialist is when you are having a difficult to treat patient. Otherwise, OSA is fairly simple. You can do the stop bank, identify them, and do the sleep study. If there are no complications, a level 3 study, and then start them on the treatment. But if it is a complicated case, it is better to be treated in a center which can handle it. Thank you so much for the opportunity, and I'm extremely sorry for the net disconnection. Thank you, sir.
Well done, Supraja. Hello.
Thank you. Thank you, Dr. Supraja. That was a clear, crisp, and enlightening overview of sleep. You sent a right message across all medical specialties on how sleep is important. Are there any questions from the audience?
Dr. Tilaga?
Yes.
Yeah,
Yes,
most of the participants are the family physician and general practice.
Yeah.
So, I'd like to know the simple screening procedure by the family physician to diagnose OSA. Simple screening procedure. What do you want to advise?
So I think she has already, Dr. Supraja has enlightened, but let me put it here. So there is a group of children and female sleep apnea patients who don't fit into any questionnaire. They will have vague symptoms. They will be with the psychiatrist. They will be with all kind of other specialties where you can't even pinpoint that this is the symptom, which is a sign or symptom of OSA. So it is only in these obese males, all these questionnaires work very well. Unfortunately, at this present time, we have to rely on Epworth Sleepiness Scale, which gives you an insight into whether the patient is really having a sleep issue, where we have to proceed with polysomnography. The other one is the stop bank and other things which assess the risk of OSA. So we have to go initially only with the Epworth Sleepiness Scale. But in females and in children, the symptoms are so vague. I hope the guidelines come up with another questionnaire where female OSAs and females can be targeted, because female symptoms are so subtle and they don't come with the real questionnaire. This is where my difficulty is. But if you have a patient with a metabolic syndrome, refractory hypertension, especially 2 or 3 drugs of hypertension not controlled, I think these patients, if you give them that questionnaire, you'll get an insight into their sleepiness, and you should go ahead with further testing in these patients.
Yeah, thank you, ma'am. Supraja, only one basic question to you, Supraja.
Yes, sir.
You told the OSA categorization, central cause, peripheral cause. I agree with you.
Yes.
What is the effect of the present device to tackle both or only peripheral?
So if it is going to be a obstructive sleep apnea, CPAPs are more than sufficient. Even a well-titrated manual CPAP, the cost of these CPAPs are the ones which are important. Manual CPAP starts at 35,000. The auto CPAP is from anywhere from 50 to 78,000. Now, when it is a central sleep apnea, when it's a central sleep apnea, you cannot do with auto CPAP. You have to go for a bilevel PAP.
The acceptance of the machine devices are not much. In your cases, what is the percentage of rejection? Rejection means not accepting.
Yeah, agreed, sir. It is very high. So 60 to 70% of the people, I wouldn't say 70% of the people, I would say 50 to 60, I try to convince. 40% is still a failure for me. But I am in a center which deals with sleep. So
yeah, definitely. I agree with you. Well done, Supraja.
Very high. Yes.
So
well done. God bless you.
Point here. So in literature, you will see that obstructive sleep apnea and central sleep apnea is as though it is a separate entity. But you often see obstructive sleep apnea patients having central sleep apnea, or sometimes after CPAP, they have treatment emergent central sleep apneas. So the thing is, if the failure rate or the intolerance is very high because you have not chosen the right mask, you have not chosen the right device for the right patient. So you should be very clear who you should give bilevel and who you should give CPAP. If you only look at AHI, you will prescribe only CPAPs. But if you do an ABG and then you see PCO2 retention is there, that person is not going to tolerate CPAP. So he needs a bi-level upfront. If you put these patients, that is COPD, OSA, overlap syndrome without an ABG on CPAP, and then the failure rate is going to be really high. I think you are the crucial person. If we analyze the problem, choose the right device for the right patient, I think the tolerance or the rejection rate is going to be very, very insignificant.
Thank you, Dr. Tilaga. Thank you, Supraja, and thank you, Jayaraman.
Thank you very much, sir. Wonderful.
If there are no more questions, can we close this session, Dr. Jayaraman?
Yes, ma'am. There are no questions. There are certain questions in the chat box, ma'am. One question is initiation of CPAP settings. How to setting in the CPAP machine for initiation of CPAP? Question from Dr. Ram.
Okay, CPAP. There is something called titration study. So in CPAP, you are supposed to do a study with the CPAP to find out whether the hypopnea, apnea, and the arousal index all are to acceptably low levels. Guidelines have given clear numbers on all those things. So you should have an auto CPAP in the first 2-3 days, and then look at the titration and prescribe that setting. If you don't have an auto CPAP device, like you have to go to a center where the sleep study is done without CPAP, with CPAP. That is a titration study, and then you should find out what is the correct ideal pressure. And if your pressure is going on increasing, your patient is not tolerating, look at the interface, look at other factors, whether patient needs bi-level, and then it goes on and on. Like the titration study is the one thing which will help either at home or at the sleep lab.
Thank you, madam. Another question from Dr. Chitra, ma'am, is asking about in which places they do sleep studies.
The Dr. Supraja Center is doing level 1 study. And other places, I think most of us do home sleep study. If you want a Pakka sleep study, as she already enlightened you with all the EEG, you want to look at the arousals, you want the cardiovascular index, everything, you should go for a proper level 1 study. That is the guideline recommended study. All the others are inferior to this. But then if your patient cannot sleep, you have other issues, cost factor, or the patient can't go to a different place to sleep, you want to do it in your home and other things, you can do a level 2 study, which is fair enough.
Thank you, madam. Thank you for this wonderful moderation by Dr. Telagudi ma'am, and wonderful speak by Dr. Supraja ma'am. It's a very crisp and clarity messages you have given. So very nice to, in this World Sleep Day, there are a lot of take messages. Generally, sleep is a very much under-recognized field. So a lot of awareness to be, we have to create. That's why this year theme is sleep equity for global health. That's important we have to give. Otherwise, a lot of metabolic issues, not only metabolic, a lot of communicable and non-communicable diseases so arising because of this lack of sleep. So thank you, Supraja ma'am, for the wonderful presentation, and thank you, Dr. Telagudi ma'am, for this wonderful moderation. So thank you. If there are no questions, let's move on to the next session. Thank you, Supraja. Thank you, Telagudi ma'am. Bye, ma'am. Thank you. Sendil sir, shall we move on to the next presentation?
Yes, sir. Yes, sir. I want to share this thing,
next presentation. Okay. Yeah. Please take over and start the introduction of moderator and the topic. Yeah.
The pulmonologist, he did his MBBS and DPCD from Madras Medical College. He finished his DNB pulmonary medicine in the CMC Vellore, sir. He is the senior consultant pulmonologist in SIMS Hospital and Rela Institute of Medical Science, Chennai. He has presented so many research papers, and he is a very renowned pulmonologist. Welcome, Dr. Suresh, sir. Over to you, sir.
Thank you. Thank you so much, Dr. Sendil, for that kind introduction. So this is, about World TB Day. I thank Dr. Jairam to invite me as a moderator for this session. So basically, the tuberculosis is still there in our country, and as in a study suggests that the diagnosis of tuberculosis takes longer time. So a patient has to see 3 doctors before he is getting diagnosed as tuberculosis. So that's the status even now. And many of us are not very much updated about the diagnosis, the recent diagnostic methods in tuberculosis, and even pulmonologists like us, we do less of TB than the other diseases. And without wasting the time, I will introduce Dr. Shanmuga Priya, who is an expert in treating tuberculosis, and she is an assistant professor currently working in Department of Respiratory Medicine in Sri Lalitambigai Medical College and Hospital. And Dr. Shanmuga Priya has done her master's in pulmonary medicine, and she has presented lots of papers and research works in international and national meets, and she is very experienced in TB programs, and she is also experienced in treating complex cases of tuberculosis. And over to you, Dr. Shanmuga Priya.
Yes, sir. Good evening, sir.
Yeah, good
Is
evening.
it audible, sir?
Yeah, it's audible. Please.
Yeah. Okay, sir. Okay, sir. Good evening, everyone. And I would like to thank IMA and Dr. Jayaraman, sir, for giving me this wonderful opportunity. And I would like to thank Dr. Suresh, sir, for the introduction. So the topic today I'm going to discuss about is update in TB diagnosis and management. So every year, World TB Day falls on 24th March 2024, and it continues with the theme "Yes, we can end TB." But TB is still one of the world's deadliest disease, and recent years we have seen a worrying increase in the drug-resistant tuberculosis. Next slide. So, in 1/3 of the world populations, 2 billion people is infected with tuberculosis, and every year 9.6 million people is sick with active TB, and 480,000 people are infected with multi-drug resistant TB, and 1.5 million deaths were found. Next slide. So, to reduce the global TB burden, we need accurate and efficient diagnosis. If there is any delay in diagnosis or health system failure, it often results in missed or late diagnosis with serious consequences of TB. Next slide. Today, I'm going to tell about the available options for the laboratory diagnosis for tuberculosis. Next. So these are the available microbiological diagnosis currently we are using. One is smear microscopy. Under smear microscopy, we are doing Zeal-Nielsen staining and fluorescence staining, and culture method. These tests, all the test is being done for active tuberculosis, and culture technique is a gold standard test for diagnosing tuberculosis. We use a solid and liquid culture, and we do use molecular method such as PCR and CBNAT, Gene Expert, and Line-Bro assay. And for latent TB infections, we will do a tubercle skin test or Mantoux test, an interferon gamma release assay, IGRA test, and other tests which are not being routinely used are lipoarabinone assay and AD, adenosine deaminase. Next slide. Next slide. So for microscopy, as I told you, we will do a conventional method and a newer method. In conventional, we use a microscopy, light microscopy, and the technique and stain we use is Zeal-Nielsen stain, and which gives a sensitivity of 30 to 94%. Zeal-Nielsen method, we use as a Corbel fusion stain and acid alcohol as a decolorizer and methylene blue as a counter stain. Here, the organism, TB organism, will look like, stained red with a blue background, and it confirms the acid fast property of mycobacteria. And fluorescent microscope, we use a Oramin rhodamin stain. Here the sensitivity is 50 to 97%, and it is used for detection of mycobacteria. Here we use a dye which binds with mycolic acid and fluorescence under UV light. Here the organism will appear yellow or orange under UV light. Next slide. So advantages of smear microscopy, the results can be given in a same day, and it is inexpensive, it is widely available, and it can be used for treatment monitoring. And we also have a certain limitations, like it can be used mainly in pulmonary TB, and it gives a low sensitivity among all cases, and it's not accurate for children or people with HIV, and it doesn't give information on drug susceptibility, and it cannot distinguish mycobacterium from other related bacteria. Next. So next is culture technique. We have a solid and liquid culture. Solid culture, we used egg-based media and agar-based media. In egg-based media, we are using a Lowenstein-Jensen media, and agar-based is Middlebrough 7H10 or 7H11 media. Where in liquid media, we use MG80, Mycobacterium growth indicator tube, or Bactec technique. Next slide. So what are the advantages of solid? Solid is more sensitive than microscopy. The average time for detection of mycobacteria is 4 to 6 weeks, and it is useful for smear negative as well as for positive, and drug susceptibility can be performed in solid culture media, and it is useful for follow-up also. In liquid, the growth detection period is 10 to 12 weeks, and it is a golden standard test, and it is more sensitive than solid culture. Next slide. So liquid culture, automated liquid culture. One is Mycobacteria MG80 growth indicator tube. It consists of liquid growth medium, and it gives a better recovery and faster growth. And another one is Bactec. It is more sensitive and efficient and rapid than LJ medium. So advantages is these automated liquid cultures are considered the gold standard for isolating mycobacteria. They increase the yield by 10 to 20% compared with solid media, and it is used for culture and DST results in saving time. Where limitation is, it is prone for more contamination. It requires stringent quality assurance system. It is more expensive, and it needs a requirement of well-trained staff with extensive technical expertise. Next slide. Next is molecular method. NAT is nothing but nucleic acid amplification test. There are different types of molecular method. One is polymerase chain reaction, real-time PCR. Third is transcription mediated amplification. Fourth is loop mediated amplification. And fifth is line probe assay. Next slide. So nowadays the real-time PCR replacing the older method. Next. So this is a process where real-time PCR has been undertaken. First is we have to do the sputum liquefaction and inactivation with the 2:1 sample reagent. Second, we have to transfer the 2 ml material to the test cartridge, and we have to insert the cartridge to the MTB rifampicin test platform, and the sample is automatically filtered and washed in the machine, and ultrasonic lysis of filtered capture organisms to release the DNA. Then DNA molecule is mixed with dry PCR reagents. Next step is we will do a real-time application and detection in an integrated reaction tube. Finally, results are given in a printed form, and the results will be whether the mycobacterium is detected low or high, and rifampicin resistant with rifampicin resistant detector or not detected. So results can be we can get the results within 1 hour 45 minutes. Next slide. So GeneXpert is nothing but a cartridge-based nucleic acid amplification test. It was endorsed by WHO in 2010. It was recommended in 2013 for the diagnosis of pulmonary TB, pediatric TB, extrapulmonary TB, and rifampicin-resistant, multidrug-resistant tuberculosis. Next slide. So what are the advantages of GeneXpert? It can give a better sensitivity and specificity and rapid results within 2 hours. So it can distinguish the NTM versus Mycobacterium tuberculosis. No technique expertise required in as such in GeneXpert. Limitations: blood, stool, urine are not recommended, and low sensitive in pericardial, ascitic, synovial fluid, and pleural fluid. It is very expensive test, and susceptibility tests for other drugs cannot be performed, and it is not advised for follow-up cases, and infrastructure is required for GeneXpert. Next. So this slide shows a different sample which has been taken for GeneXpert and which shows the sensitivity and specificity. So sputum can give 88% sensitivity under GeneXpert diagnosis, where specificity is 99%. Lymph node is 84% and specificity is 92%. Cerebrospinal fluid will give 79% sensitivity for GeneXpert and specificity is 98%. Pleural fluid will give you 43% sensitivity and 98% in specificity, where gastric lavage or aspirate will give you 83% sensitivity and 98% specificity. Next slide. Next is TrueNAT test. So TrueNAT is nothing but it utilizes a chip-based real-time micropolymerase chain reaction (PCR) for detection of tuberculosis, and we can detect the rifampicin resistant from DNA that is extracted from sputum sample within an hour. Next slide. LinePro assay. It is also a strip-based test technology. It was used to diagnose tuberculosis and detect both rifampicin and isoniazid resistance, which is distinguished from the GeneXpert, where in GeneXpert we can find only rifampicin resistance, but in case of LinePro assay, we can detect both rifampicin as well as isoniazid. Here, due to mutation in RPOB and both INHA and CATG genes. So in LinePro assay, the steps are we have DNA extraction and amplification by PCR, and third finally is hybridization. Next is evaluation. Next slide. Advantages, quick results in under 48 hours. It is more accurate, and WHO recommended the test for detection of resistance against additional drugs, and it is necessary for guiding treatment decisions. And disadvantages, it is expensive. Again, it needs a well-trained staff in a professional laboratory, and it has a high biosafety requirements, and it is not as fast as GeneXpert. Next slide. As I told you earlier, this test is not routinely used. It is called LAM, Lipoarabinomannan assay. And next. It was introduced in 2015. It is especially done from urine of active TB patients, and reference scale card has given on the left side, and it is used only in HIV patients presenting with the TB symptoms and CD4 counts less than 100 per microliter. Next slide. Next is tuberculin skin test, where I told you earlier for latent TB infection, we can do a TST and IGRA. TST, one is Mantoux test or TST test, another one is interferon gamma release assay. Next slide. Tuberculin skin test, also known as a Mantoux test. It is a skin test to detect if you have been infected with the TB bacteria, where small amount of purified protein is taken from the dead TB bacteria and it is injected under the top layer of the skin on the forearm, and results can be read within a 48 hours. So advantages, it is a screening test for latent TB diagnosis, and limitations, it has a limited value in the diagnosis of active TB. Sometimes false negative reactions is common in immunosuppressed patients, and false positive reaction is seen in NTM and BCG vaccination. Next slide. Interferon gamma. It is an in vitro assay that measures the T cell release of interferon gamma in response to stimulation with the TB specific antigens ESAT6 and CFP10. These two tests are commercially available. One is quantiferon TB Gold and T-Spot TB test. These are the interferon based tests which are commercially available nowadays. Next slide. So advantages, it is more specific than TST due to less cross reactivity with the BCG vaccination and NTM. And disadvantages is it has a limited value in the diagnosis of active TB as TST, including extrapulmonary TB, and positive IGRA may not necessarily indicate the active TB, and negative result would not conclusively rule out the active TB in an individual suspected to have a TB. Next slide. So the following 3 to 4 slides, it is a collective table which gives methods, recommended use, and limitations, advantages, and cost of the available diagnostic tools. So you can go with the next slide. Next. Okay, this is a recommended test for the specimen for pulmonary and extrapulmonary TB. For pulmonary TB, if sputum is a required specimen, and we can do the following tests for sputum detection: smear microscopy, liquid culture, and CBNAT. For TB lymphadenitis, the specimen is lymph node aspirate, and diagnosis can be done with smear microscopy, liquid culture, and CBNAT. These are the choices of test for the different types of TB. And for pleural TB, the specimen is pleural fluid, and test we can do a ADA test with the pleural fluid, and IGRA will be helpful, and we can do other biochemical analysis from the pleural fluid. Next slide. So for genitourinary TB, specimen will be the urine, and the recommended test is culture and TB PCR. And for males, it is a prostatic secretions. For female, it is endometrial biopsy tissue, where the both specimen can be sent for CBNAT or gene expert. For POTS disease, the specimen is first drained from the abscess or synovial fluid, and recommended test is culture or histology. Next slide. Next. So for TB meningitis, it is also one of the type of extrapulmonary TB. The specimen is cerebrospinal fluid, and recommended test is CBNAT culture.
Yeah, conclusion on TB diagnosis. So TB screening and diagnosis require a combination of different methods and technique to accurately test people, and there is no single TB test that can do it all. So culture remains a gold standard for the definitive diagnosis of TB in smear negative patients, and culture technique should be used for monitoring treatment response or follow-up of cases. Molecular methods are promising with a very low turnaround time, and suspected multi-drug resistant or extensively drug-resistant cases, first diagnosis choice should be the CBNAT or LPA. Next slide. Now I move on to the second part of my talk, management of tuberculosis. Here the integrated, this slide shows the integrated management algorithm for TB diseases and TB infection. Now we define TB as a presumptive TB, and once we suspect a presumptive TB, we have to do a nucleic acid amplification test or microscopic test or chest X-ray. So if chest X-ray is positive, we will treat them as a drug-sensitive tuberculosis. If nucleic acid amplification is positive, whether it detects MTB and it is sensitive to rifampicin, we have to find out whether it is sensitive to isoniazid or it is resistant to isoniazid. If it is sensitive to isoniazid, again, we have to treat as a drug-sensitive TB. If it is resistant, we have to treat as isoniazid mono or polydrug-resistant TB. And second category is MTB positive, but rifampicin resistant. If it is rifampicin is resistant, we have to find out whether it is sensitive for fluoroquinolone. It is sensitive for fluoroquinolone, then it will come, treatment is MDR or MDR TB or rifampicin resistant TB. If it is fluoroquinolone resistant, then we have to treat it as a pre-XDR or XDR TB, extensively drug-resistant TB. Next slide. So these are the mandatory action at health facility level. We have to counsel the TB patients and family members on diagnosis, contact screening and TB preventive treatment, nutritional assessment, comorbidity care, and follow-up visit and investigations, and adverse effect reporting and long-term follow-up. We have to tell them the risk assessment of TB patients for differentiated care, and we should initiate the DST guided regimen. And we have to collect the bank detail collections for Nikshay Poshan Yojana, and we should follow the treatment, and we have to screen for comorbidities like HIV and blood sugars. Next slide. So this, that is previous slide is action at a healthy level, and it is action at a community level. So community level, we have to do a home visit by health worker, preferably within 3 days of diagnosis. And same as previous slide, we have to counsel them for all these. And for contact investigation, we have to refer to health facility for further clinical evaluation to rule out the active TB. If it is active TB, we should start a ATT drugs. If it is not an active TB, we have to initiate the TB preventive treatment. Next slide. So this is a drug regimen which we are following now. One is drug susceptible TB. For a drug susceptible TB, the regimen is drug susceptible TB regimen, which is nothing but 2 months of isoniazid, rifampicin, ethambutol, and pyrazinamide, and 4 months of isoniazid, rifampicin, and ethambutol. Now we are giving a daily regimen with a fixed dose combination where 4 tablets content will be in the same single tablet, and the patient has to take the tablets each every day. And second one is isoniazid monoresistant or polydrug resistant TB. Here the regimen is 6 months of levoflox, rifampicin, ethambutol, and pyrazinamide. Third is MDR TB or XDR TB. For MDR TB, we should give shorter oral bedaquiline containing MDR-TB regimen or shorter injectable containing MDR-TB regimen or oral longer MDR-XDR-TB regimens. These are the regimens which has used for MDR and XDR-TB. Next slide. Now we are giving a preventive treatment for all patients who are at risk or history of contact with the TB patients. So TB preventive can be given under the basis of 6 months daily isoniazid monotherapy. Either we can give isoniazid monotherapy for 6 months, or we can give 3 months weekly both isoniazid and pyrazinamide for 12 dosages, or we can give in case of MDR or rifampicin resistant TB, we can use 6 month daily levofloxacin with the fluoroquine sensitive index patient. In case of rifampicin sensitive index patient, we can use 4 months daily rifampicin in contact of H resistant with the rifampicin sensitive patients. So these are the TB preventive treatment which is available and currently used for all the TB contact patients. Next. So I would like to thank everyone for your patience hearing. Thank you, sir.
Thank you very much, Dr. Shanmugapriya ma'am, for a wonderful insight talk on the TB diagnosis and management with the latest thing. The culture is the gold standard. So we have to adhere the treatment regimens properly as per the government. And we have to, our aim is to eradicate tuberculosis completely, and TB by 2025. So we'll fight against the tuberculosis, one of the commonest infectious killer disease in the world in our countries. So this is our aim behind that. So thank you very much, Dr. Suresh, for this wonderful moderation. So thank you all for this wonderful thing. I thank the first speaker, Dr. Sugashini ma'am. He has spoken in detail about the glaucoma diagnosis and management, and wonderful moderation by Professor Dr. Nirmal Frederick sir for the nice insight on that. He is the Ophthalmic Association President of Tamil Nadu. And followed by, we have World Sleep Day talk by Dr. Subraja ma'am. He has given all the wonderful insight about the diagnosis and treatment aspect, when to suspect OSA and all, with the questionnaire, top bank questionnaire and EPO sleepiness scale and treatment modalities, multimodality. So one size does not fit for all. There are a lot of treatment, lot of phenotype, lot of genotypes are available to diagnose, pinpoint easily, and we have to make the proper treatment, individualized treatment. Nowadays, we are all practicing in a era of precision medicine. We have to diagnose precisely and treat precisely. Each and every patient is individual. So we have to have the personalized treatment for each and everybody. So a lot of take-home messages from World Sleep Day. So sleep EQT for global health. So we have to spend on sleep at least 1/3 of the life we are spending. So we have to spend on the sleep effectively. So any disturbance in the sleep or any insomnia, sleep apnea, anything, so we have to consult appropriately for the chest physician in the case of sleep apnea, because the pulmonologist is a lead in the clinical sleep medicine. So eventually, which requires any further treatment modalities like any surgical treatment or any PAP treatment or any the oral devices and all. So in these special occasions, we did a wonderful talk on World Glaucoma Day Awareness Talk and World Sleep Day Awareness Talk and World TB Day Talk. So I thank you all the speakers and moderators and the delegates and our team for this wonderful